Abruption placenta versus placenta previa.
Abruption placenta, or placental abruption, is a critical pregnancy complication where the placenta, the organ that nourishes the developing baby, prematurely detaches from the wall of the uterus. This separation occurs before the baby's birth, typically after 20 weeks of gestation. It's a detachment issue, disrupting the vital connection between the mother and the baby. The placenta is a temporary organ that develops inside the uterus during pregnancy. It acts as a lifeline, providing the baby with oxygen, nutrients, and waste removal. This exchange of oxygen, nutrients, and waste products happens through the umbilical cord, which connects the baby to the placenta. The placenta should normally detach from the uterine wall after the baby is born. This typically happens within 5 to 20 minutes following the delivery of the baby, during the third stage of labor. This stage begins after the baby is born and ends with the delivery of the placenta. The uterus continues to contract after the baby's birth. These contractions help to separate the placenta from the uterine wall. So what happens in placental abruption? When the placenta detaches from the uterine wall, the baby's supply of oxygen and nutrients can be compromised. The detachment also causes bleeding, which can be dangerous for both the mother and the baby. The bleeding can occur between the placenta and the uterine wall, or it can be visible as vaginal bleeding. While the exact cause of placental abruption isn't always known, several factors can increase the risk. These include chronic hypertension, preeclampsia, history of abruption, premature rupture of membranes, abdominal trauma, smoking and cocaine use, and multiple pregnancy. Women with chronic high blood pressure are at increased risk. High blood pressure can damage blood vessels, including those supplying the placenta, making it more prone to separation. Preeclampsia. This is a pregnancy-specific condition characterized by high blood pressure and protein in the urine. Preeclampsia can also affect the blood vessels in the placenta, increasing the risk of abruption. History of abruption. Women who have experienced a placental abruption in a previous pregnancy are at a higher risk of having it again in a subsequent pregnancy. Premature rupture of membranes, PROM. This is when the amniotic sac, the bag of fluid surrounding the baby, breaks before labor begins. PROM can sometimes lead to placental abruption, possibly due to the sudden change in pressure within the uterus. Abdominal trauma. Any direct trauma to the abdomen, such as from a car accident, fall, or physical abuse, can cause the placenta to separate from the uterine wall. Smoking and cocaine use during pregnancy are strong risk factors for placental abruption. These substances can constrict blood vessels, reducing blood flow to the placenta and increasing the risk of separation. Multiple pregnancy. Women carrying twins, triplets, or more are at a higher risk of placental abruption. This may be due to the larger placental mass or the increased pressure within the uterus.
Signs and symptoms. Remember the word detached. D for dark red painful bleeding. Vaginal bleeding is a common symptom, but it's not always present. The blood is often described as dark red. Crucially, the bleeding is often accompanied by abdominal pain, unlike some other causes of bleeding in pregnancy. However, in some cases, the bleeding may be concealed. E for extended fundal height. The fundal height may be greater than expected for the gestational age. This can be due to blood accumulating behind the placenta. T. For tender uterus. The uterus may be very tender to the touch, and there may be constant abdominal pain or cramping. A. Abdominal pain or contractions. Abdominal pain is a hallmark of placental abruption. It can range from mild cramping to severe constant pain. Contractions may also be present. C. For concealed bleeding. In some cases, the bleeding may be concealed, meaning it's trapped behind the placenta and doesn't appear externally. This can make the diagnosis more challenging as there may be no visible blood. This is a particularly dangerous situation as the lack of visible bleeding can mask the severity of the abruption. H. For hard uterus. The uterus may feel hard or rigid due to the sustained contractions or the blood accumulating within the uterine wall. E. For experienced DIC, or disseminated intravascular coagulation. DIC is a serious complication where the body's clotting system goes into overdrive and then fails. These can lead to excessive bleeding both internally and externally. This is a late and very serious sign. And lastly, D. For distressed baby. Signs of fetal distress, such as decreased fetal movement or an abdominal fetal heart rate, may be present. This is a critical sign that the baby is not getting enough oxygen. Nursing intervention. Monitoring for signs and symptoms of disseminated intravascular coagulation is essential. Watch for decreased platelet, fibrinogen, and prothrombin levels, as well as signs of bleeding, such as gum bleeding, oozing from the IV site, petechiae, and echinosis. Be alert for chest pain or shortness of breath. Monitor the fundal height and fetal heart tones, continuously using an external fetal monitor. Remember to avoid abdominal, vaginal, or pelvic exams to prevent complications. Position the patient in a lateral position with oxygen support to optimize fetal and maternal oxygenation. Take and record maternal vital signs every 5 to 15 minutes to stay on top of any changes. Prepare for possible blood transfusion if indicated, and be ready to prepare for delivery at any moment.
Placenta previa is a pregnancy complication where the placenta implants in the lower part of the uterus, covering all or part of the cervix. This condition can lead to complications during delivery, often necessitating a cesarean section. Here are some causes of placenta previa. The first one, previous uterine surgery. Women who have had surgeries on their uterus, such as cesarean sections, myomectomy, or abortions, are at a higher risk due to scarring that can affect placental implantation. Second, multiple pregnancies. Having multiple pregnancies, such as twins, triplets, etc., increases the likelihood of abnormal placental positioning due to changes in uterine structure and size. Third, maternal age and lifestyle factors. Women over the age of 35, as well as those who smoke or use cocaine during pregnancy, have an increased risk of developing placenta previa. These factors contribute to the abnormal placement of the placenta, which can obstruct the birth canal or lead to complications during delivery.
In a typical developed pregnancy, the placenta, which nourishes the baby, develops high up in the uterus. Sudden vaginal bleeding may indicate placenta previa. The placenta has partially or totally grown over the cervix. If the attachments of the placenta to the uterus are damaged, the resulting bleeding may lead to hemorrhagic shock for the mother and lack of blood flow for the fetus.
This condition can occur at any stage of pregnancy, but is most commonly diagnosed in pregnancy or trimester. The placement of the placenta in this location poses significant risks during labor and delivery, as it can lead to severe vaginal bleeding and complications for both the mother and the fetus. Depending on the extent of coverage, placenta previa may necessitate careful monitoring throughout the pregnancy and often requires a cesarean section for delivery to ensure the safety of both mother and baby.
Types of placenta previa. First is low-lying placenta. The placenta is positioned in the lower part of the uterus but does not cover the cervix. Second is marginal placenta previa. The placenta reaches the edge of the cervix but does not cover it. Third is partial placenta previa. The placenta partially covers the cervical opening. Fourth is complete placenta previa. The placenta completely covers the cervical opening. Signs and symptoms of placenta previa. First is vaginal bleeding. The most common symptom is painless, bright red vaginal bleeding, typically occurring after the 20th week of pregnancy. Second is abdominal cramping. Some women may experience mild cramping or contractions in the abdomen, belly, or back. Fifth, emergency response. Be prepared to respond promptly to signs of severe bleeding or fetal distress. Ensure that emergency interventions, such as resuscitation equipment and medications, are readily accessible. Second, patient education. Educate the patient about the condition, potential complications, and the importance of adhering to medical advice. Instruct the patient to avoid activities that could trigger bleeding, such as sexual intercourse and strenuous exercise. Third, supportive care. Provide emotional support to alleviate anxiety and stress. Encourage rest and, if advised by the healthcare provider, limited physical activity. Fourth, preparation for delivery. Prepare for potential cesarean section delivery, ensuring all necessary equipment and personnel are available. Coordinate with the healthcare team to plan for blood transfusion if significant bleeding occurs. Fifth, emergency response. Be prepared to respond promptly to signs of severe bleeding or fetal distress. Ensure that emergency interventions, such as resuscitation equipment and medications, are readily accessible.